Ethically, it must be recognized that dual patient ventilation is not the usual standard of care. However, in the setting of a mass crisis, the number of critically ill patients may exceed the number of ventilators to support them. With some safety measures in place, this approach offers the best chance at saving the most lives. The use of dual patient ventilation should be discontinued as soon as a sufficient supply of ventilators becomes available. Hi there, it's Claudia Poulin from Hamilton Health Sciences, just demonstrating a dual patient ventilation strategy using a single mechanical ventilator, and this would be done during a severe critical shortage of mechanical ventilators. So here we have rigged up a system. I'll just kind of scan it, how it looks with two patients. Okay, so we have an inspiratory line, and of course we've got the viral bacterial filter that is the manufacturer recommends. And then we have a T connector. The red line is our patient B, and in there is a directional flow control valve that we've added. And then the other is patient A, and we'll just move up the line here. The next section of the circuit demonstration shows A, an end-tidal adapter, and B, a pressure sample line connector with lure lock. Next, it's a heat moisture exchange filter, and then the two test lungs. So patient A is our most critical patient, and then patient B is our least critical patient, and we've added the directional flow control valve with that. And I've got pressure monitoring connected to both patients. Okay, so right now this directional flow control valve is open. I'm just going to let George explain what he used when he made this, and then we will close it and see the variances between the two circuits. This valve can be inserted to change the pressure for each connected patient. George Boyce will explain how he prepped the directional flow control valve he purchased from a plumbing store.
Thanks, Claudia. It's George Boyce from the Biomed Mechanical Department of Hamilton Health Sciences. What I've done is I've procured a valve, a 3/4 pipe thread to fit. That's the closest match that I wouldn't inherit any flow. A barb fitting on both sides of the valve. The seal inside the valve is compatible for oxygen. So what I've done is I've completely deburred all of the brass fittings, taken the valve apart, deburred it as well, and then I cleaned it all up, washed it out, and blew it out with compressed air to make sure that there was no metal cuttings remaining inside. Then I actually wire brushed inside through the valve with a, not a wire brush, but with a bristle brush. Then flushed it out again and washed it again. And then I immersed it in alcohol and then compressed air to actually evaporate any remaining water and if there was any other particles in there. Reassembled the valve. Teflon taped the threads, tightened them up like a normal plumbing job. And then I wrapped up Teflon tape on the barb fittings to ensure that there was a press fit for the circuit to be pressed into it. Right now the valve is wide open, so it's being fairly identical from patient A to patient B. And if I slowly turn the valve down, within a cycle or two of the ventilating, you'll notice that patient B's intake and expiration will be changing. By turning the valve down, you can see the different capacities of each of the artificial lungs.
Okay. Something that I didn't mention is on the expiratory line, we did add one-way valves. Those are one-way check valves to ensure that there's no backflow between the patients. Some clinical considerations is using pressure control mode to ensure that if there was an airway obstruction or other acute changes in one patient, the other patient will continue to receive the same ventilatory support because driving pressure is unchanged. In contrast, with volume control, if one patient experiences an acute change, the unaffected patient would receive a much higher tidal volume or an increase in peak inspiratory pressure, which could be of concern. Next, because tidal volume and minute volume readings on the monitor reflect the additive values from both patients combined, it is essential that ventilator alarms be adjusted expertly to detect small deviations in either of these parameters. Lastly, it is imperative to have both patients either paralyzed or deeply sedated to ensure that neither patient triggers the ventilator.